Okay. Listen, let's get into it. Dr. Titus Beyuo is a senior lecturer at the University of Ghana Medical School. He also happens to be NDC parliamentary candidate for Lambusie. I've said that right, haven't I?
Correct.
Yes, which is in the Upper West region. I think I've driven through Lambusie before. Good to have you. Good morning.
Good morning, Kojo. And I'm sad that we have to talk about this again and again and not arriving at a solution. I think my opening comment will be that perhaps we are asking the wrong question and at the wrong place as well. I can sympathize with the management of Korle-Bu with all the backlash on them and the pressure, and then the ministry says we've instructed Korle-Bu to open, but we are doing nothing about the elephant in the room. There is a cost to dialysis. There's no doubt about that. Everybody agrees that there's a cost to dialysis. And because Korle-Bu is not meeting that cost, Korle-Bu has incurred a debt of about 4 million Ghana cedis. We were promised that government was going to settle this. This was more than a month ago. I think I was on set for that thought leadership discussion where the presidential advisor on health said that government was going to handle this. I remember either you or Evans putting it to him directly when they were going to pay it and if it would be committed. Initially, he said they were having interactions here and there, and then you wanted a direct word of confirmation. And we got something like that they were going to settle it. So when we go back to Korle-Bu and ask, when is Korle-Bu opening the center to OPD, I think it's a wrong question. And it's wrong also to the wrong person, because we should be asking, has the debt been paid? What is the subsequent financing model going forward? If we haven't answered and these cannot be answered by Korle-Bu, it has to be answered by the ministry and the government. But Korle-Bu has come up with how much it's going to cost them to continue to keep this dialysis. Now, we have done this wrongly a few times in the past, and we keep getting wrong results, and we are doing the same thing, where with power pressure and a political or an administrative fiat is issued, and at the end, it's trouble. And I can give you at least a few examples. There is a policy that if you get an accident in this country, when you get into the hospital, first 24 hours, your care is free. Is that free? Who is paying for it? You get involved in an accident and appear in the hospital, even if you are unconscious. Somebody got to offer some money to do something for you to get care. So we set up DOFSU. When we brought that act, a fund was supposed to be created from which victims will be paid. How many years has the act been passed into law? Where is the fund? Do the victims get any money? No. And it's always because when there is pressure on the politicians, on the public and government, then they easily pass their back to the agency without solving the problem. I can promise you that if we don't ask the right question and get the right answer, the opening that Korle-Bu has declared open now is only going to take us to a state where we are worse off than where we began. What do I mean by worse off? We are going to get to a place where, one, even those who have money cannot get the dialysis. Because if they use up all their consumables, because they've been forced to use them. And my information is that from today, any patient Korle-Bu dialysis, for every single patient that pays the old fee of 380, Korle-Bu is going to accumulate a debt of another 380 per session, per patient.
So the debt has started accumulating again? Immediately.
The CEO mentioned to us that they need about 961,000 Ghana cedis a month to sustain the dialysis at the current rate. This is where that debt comes from. So if we haven't answered this question, what it means is that they are going to run out of consumables. They are not going to get consumables. And now my patient, a pregnant woman who is not having any chronic hypertension, whose only sin she has committed is being pregnant, trying to bring another human being into this world and develop a complication like eclampsia or preeclampsia with acute kidney injury, who is potentially curable. This is different from people with CKD. For those with acute kidney injury,
CKD if they get is chronic kidney disease.
Yes, but for the acute ones, when they get dialysis, 2, 3, maximum 5 sessions, their kidney takes up. and they are fine. These people are not going to even get the dialysis. So that is how we should see the problem. And then ask the hard questions. How do we get ourselves out of here? And you notice the difficulty with which Korle-Bu had to open. The instruction had been given. We have asked Korle-Bu to open, and for quite some time, Korle-Bu couldn't open simply because the there is not there. It's not there. So we need pragmatic solutions. And if we haven't solved that, then just like has happened to all other instructions that government gives, and one of the easiest things that's going to happen, which I am afraid of, is with so much pressure and people saying everything, a government will just get up and say, I'm asking the NHIS to take it. And then we'll all clap for them and we'll go to sleep.
And
But
then people will really start dying.
That has been done already, because yesterday the PRO of the Ministry of Health indicated that the president had directed
Good.
that the NHIS should cover it.
So these directives in vacuum, what is happening? The NHIS, that its funds are capped. The government in 2017 passed an act of parliament, and it was assented quickly in April, to cap earmarked funds. And the number one on that list of 16 funds is NHIL. So all our contributions we are doing to the NHIL, the funds are capped. And now if you follow the principle of it, I'm not an economist, but my basic understanding of it is that there is that capping of all our total tax revenue that goes to these earmarked funds. They are not allowed to pay more than, it was initial 25%, they've dropped it to 17.5%, and we are all quiet. And they'll continue further, the next maybe 5%, we don't know. So they are not allowed to pay more than 17.5% of total tax revenue to this earmarked fund. If you go into the NHIS itself, of the total revenue that NHIL receive, it is also capped so that it can make up this bigger capping of 17.5%. How can such a body take on dialysis? And we need to know one thing. If this directive is given indeed, as has been mentioned, then it's a recipe for disaster. And I'll just give you why. Remember, we have an unmet need for renal dialysis of about 90%. For every one patient undergoing dialysis, there are 9 others who are not getting that service, who can't get that service. So if the NHIS picks it up, it means this other 9 people will show up. They will not take it as a death sentence anymore. So it means that the expenditure to the NHIS is not going to be this 960,000 I mentioned for Korle-Bu alone, nationally, which is going to be bigger per month. It's going to be that times 9. It's going to increase by 9-fold. There are 9 other people who are not getting this service, which, if it become publicly available, they should assess. And they are Ghanaians. Why not? So if we issue this directive with nothing backing it, what is going to happen, and I can predict from my years of clinical practice, and that's what's happening in a lot of issues, is that the NHIA board and everybody appointed by government cannot say no. CEO cannot say no. They will take it on. They will submit the bills. The government hospital will submit the premium, and it will be in arrears for years. Then we come back to not zero, but negative, because just as I've said in the first scenario, you are not going to have even people who have money willing to pay for the service getting it, because if the consumables are not imported and are not available, then no one gets it. So I am going to make some proposals in terms of how we should solve this.
We'll come to that. Yes, we'll come to that in a minute. But I want to bring in Kwame Sarpong Asiedu. Of course, he's a pharmacist, a D&D fellow on public health at CDD Ghana. He joins us via Zoom. And you know what we're talking about. We're talking about dialysis. The announcement has come. The OPD for renal dialysis has reopened at Korle-Bu. Let's try and understand. This is a national issue. Korle-Bu just happens to be the focal point because we know what's happening there. But there are hospitals across the country which either don't even have dialysis facilities or have and are under extreme pressure and are charging perhaps even more than Korle-Bu is charging. And people cannot afford. People cannot queue up 9 hours a day to get their dialysis. The problems are real. Kwame, thanks for making time for us again. But listening to Dr. Titus Beyuo, I'm starting to wonder, have we made the situation worse?
Well, you shouldn't wonder. I did point out earlier that if you read the letter, if you read that letter, you should be very, very, very worried. And I'm glad Titus has pointed out a number of things that I left out when I spoke to you earlier. And so I didn't talk about the NHIS because when we did the thought leadership event, I was at pains to explain why the capping was untenable. And in actual fact, I'll go further to say it's dangerous. It is dangerous because when you have a health insurance scheme, it has to invest some of its inflows for rainy days and unexpected events like this, where the president has just given a fiat order that they should absorb renal dialysis. They haven't invested the money because the money has sat with the central government because the government decided to pass a law that bypasses the National Health Insurance Act. So when you go further to tell them that they should take on dialysis, and already anyone who's a practitioner knows that the NHIS is in arrears to service providers, you're going to not only compound the dialysis problem, but you're also going to compound the arrears that are owed to service providers because already with this money you cannot pay. And then what would happen? For the service providers, some of them might back out and say they are not going to provide NHIS service on the NHIS. But more importantly, those who are on life and death situations, like what Dr. Titus was saying, a lady who's got preeclampsia and has got acute renal failure or something like that, or someone who has had an accident or something and just needs the kidney to be given, might end up passing away because they would get to the hospital and, like Dr. Beyuo said, something that has to be free, you get to the hospital and you have to pay. Everyone knows that. It is not something you should run away from. So if such ad hoc decisions are taken, not backed by the data, not backed by the lack of fiscal space in our health budget, but are done, in my view, strictly on a populist hunch. And I'm being blunt about it being a populist hunch because, if it's not populism, Dr. Isiasari sat on a program with myself and Titus and said the money was going to be paid. Nothing happened. The Minister of Finance, the Minister of Health gave a directive. Korle-Bu turned around and said that they hadn't received the directive. Nothing happened. The Minister of State said the same thing, that it was going to be paid over the last weekend. Nothing happened. And suddenly, open, and we get this letter which says the fundamental problem hasn't been solved. So the only reason is you guys, journalists, are bashing the government too much. We cannot take the heat no more. So you, Korle-Bu, open up. The chief executive, who is appointed by the government, who knows that the president can wake up in the morning and say you've lost your job, has no choice than to open up. Is that how to run a health system? And for me, these are the critical conversations we have to have. And if you remember, when I gave my public lecture in September on the 18th, I brought these things up and said, these are the things that are biting our health system. Now we are actually seeing them in real-time play, and we need to deal with them.
Wow. Okay, so I mean, we've identified a problem, we've highlighted it, we've called for a solution, but that has set us on a path which, if nothing changes, will make the problem 10 times worse.
Yeah. Yeah.
So I mean, I mean, honestly, at this stage, what is the real risk that is posed to renal patients across the country? Let's outline the real risk if nothing changes. I'll start with you, Kwame.
The first thing, if you listen to Titus, he said that for every patient that is dialyzed at 380, Korle-Bu incurs a death of another 380.
Yeah.
When you add 380 to 380, what do you get? You get 760. So that bulk figure is by and large what Korle-Bu needs to break even. Korle-Bu is a government facility. So that if we use that as an average, what faces patients in the country is what we identified at the thought leadership event that they need about 85,000 cedis annually just to stay alive. That doesn't include their epoetin and all the other things and their vitamins and ions that they have to take. It is just for dialysis. They need 85,000 Ghana cedis. And I'm repeating this because I said it at the event, and I'm not breaking it down because I've already broken it down, and you guys have made stories, but it's 85,000 cedis if you break it down. If you look at a country where 70% of the population earn less than 3,000 cedis a month, based on the Ghana Statistical Service, it means 90% of Ghanaian workers are priced out of the dialysis market just to stay alive. So what it means is that if you are listening to us speaking about this matter and you feel that you have robust kidneys, pray that it doesn't befall you or doesn't befall your family member or distant relative, because you would have to be part of the network that will cough out that 85,000 cedis every single year.
Jesus.
And if you break 85,000 cedis by 12, you'd ask yourself, how many people can afford that and pay their bills, water, electricity, buy fuel for their car, pay their children's school fees? So, Kojo, it is not a problem that we should just sit down and paper over the cracks like the government is trying to do and be populist about it. We need to deal with it. I strongly believe that the National Health Insurance Scheme is the route to go. But if it has to be the route to go, then there needs to be capital injection. And you see, I'll end it this way, this part of the question this way. When you have a country where we are always kicking issues into the long run. For example, we all sat here, and I'll continue repeating it, when the sin tax was introduced. And dialysis is one of the sins that you can get from indulging in some of the things that the tax have been slapped on if you are not careful. We have introduced it, and that money is supposed to be a tax to alleviate your suffering when you get the fallouts from those sins. We do not have a sin fund in the country. It is not going to the NHIS. It is going to economists sitting in the Ministry of Finance and the Finance Minister to spend as they wish. So you know what happens to you? If you indulge in those sins, alcohol, XYZ, you've paid a premium to take care of you at the end of the day when you fall ill. You are also paying indirect taxes to the NHIS to cushion you. But when you fall ill, neither of the stopgaps will be there. That is the sort of planning we do in this country. We should clap for ourselves.
Kwame, I don't know how you did your calculation to arrive at the 85,000 a year, because I have had a look at 760 per session times 3 sessions a week times 52 weeks. That gave me 118,560 cedis per year.
Yeah, Kojo, because there is a range. If you looked at what we did at the Thought Leadership Program, the range is between 500 and 800. So you have to use the mean.
Very good.
And that is why I said we are dealing with government facilities.
Yeah.
If you do the calculation using private facilities, some of which charge 1,000 cedis, and you do 3 sessions, which is 3,000, and you do 4, that's 12,000, it comes to 144,000.
Right.
So I am looking at the lower level of just to stay alive.
Fair enough.
I'm not looking at the other echelons.
Okay. Well, that's the size of the problem. Okay. They've opened the renal outpatient unit at Korle-Bu, but the problem itself, dear, we haven't scratched the surface. And if nothing happens, it will only get worse. So what is the solution, Doc?
Yeah. Okay. So I think we have painted really what the picture is, and I would want to make some suggestions towards solutions. And I think we all have to realize that, yes, I'm a politician now, but I'm detaching myself from politics, because this is really a national discussion I think we should be having. Because what has been happening is that we bring issues, and then to quickly bring a political solution, we do something just to manage the situation, but we never really solve it. For us to solve this, because I am at risk, you are at risk, everybody else is at risk, we have to answer the hard questions. Unfortunately, we are answering it in a reverse manner. We are at the tail end. We have a 17% of our population with some chronic kidney disease, and we have a good number that have end-stage kidney failure, and they need to be managed, and the solution for them is dialysis and renal transplant. The little statistic I'll add before that to just give context to my solutions that I'm proposing is that we should also note that the mean age of our renal failure is younger than in most countries. It's around 45 from one study done in Korle-Bu, and the range is from like 20 to 50, which means that if the life expectancy is expected to go up, we are going to have people living with this condition for a pretty long time. So the burden must be properly assessed before we look at the solution. So having this in mind, for those who are already at the stage of dialysis or renal replacement therapy, they either get dialysis or transplant. The permanent solution for them is transplant, because an average transplanted kidney can live with you for 20 years or thereabout before there's a need to even do anything again. So if somebody who is 50 gets a transplant, that person will go off dialysis for like 20 years and they should be fine. So that is the final solution for this group of people. In the meantime, the dialysis must be made accessible and affordable. And that will not come by directives and fiats. It must come by a well-outlined policy with a financing model. I still believe, like Kwame, that the organization that is best suited, with the best expertise, with the experience and structures to manage healthcare financing in this country is still the NHIA. And so I would support a call for the NHIA to come in. But that call must not go ahead of some things being done. The first is the NHIA must be resourced. Resourced in the sense that their premium, in fact, I think the very first one, if the president is interested in doing this, is that they should go back to, should tell the finance minister to go to parliament and change that bad law. The law is bad that capped NHIS part of the earmarked funds. In fact, it's the number one listed on the list of the earmarked fund. They should take NHIS out, just as the district assembly fund has been taken out because that was found to be unconstitutional. So a single individual could challenge that. Now everything in there is legal, but it's a bad law. That is my opinion, and we can change it. So they should free NHI from that. The monies from NHI should be made accessible to the NHI. Then, only then, can we have a discussion on realistic premiums. It will make no sense for you to ask anybody to pay additional when you have capped that money, putting it in a central pool, and we do not know how you are using that money in the central pool. You are making that money available to central government for use when I am paying, thinking that when I'm in trouble, this money will come in for me. The whole purpose of insurance is that it will do for you what you cannot do for yourself. And when you are in trouble, it should be able to restore you at least to where you were before. One of the things you never mentioned when you talk about the calculations and all of that is that the minute you have this diagnosis, your income will also drop because you become economically less viable. So even if you are in your house now smiling and say, oh, they say it's 85,000, I earn 200,000 annually, so even if I get it, I can afford it. Don't kid yourself, because when you get it, you are spending 4 hours a day, and almost the entire day after that you are tired. You can't work.
9 hours a day.
Yes,
you Cape Coast.
You can't work afterwards, so you are losing 3 days a week. Your income will drop no matter what. So you will not be earning your current income to think that you can support. So let's just remember that. So I think that the NHIS must be giving money. The next thing I'll touch on is what Kwame also mentioned. The sin tax is been with us. This government has found wisdom to increase it, but like any other tax, it goes into the pool, the consolidated fund, that I'm not sure if any accountant can really do an account on that account. Because I don't know, any money that goes into that consolidated, yes,
it's a black hole into which things disappear forever.
Yes. So I think that the purpose of that tax, unless it is to punish, But if it is that when you consume these sugary drinks, you consume alcohol, you consume tobacco, you will get a non-communicable disease that will be a burden on the state. And therefore, we are charging you ahead so that when you get there, we can provide for you. If that really is the principle, then that money must be ring-fenced. And that is where that money must be earmarked and put into the NHIA or given to a body that can help us fight non-communicable diseases. Then I come to my second level, which is that at the current disease burden of chronic kidney diseases in this country and the youthful nature of it, it will be very difficult for any financing model to handle it for a long term if we don't find a way of reducing the burden. So prevention becomes key, because if you are getting kidney failure at 20, sustaining you on dialysis or even transplant for the rest of your life is not going to be easy. And our situation is peculiar because if you go globally, the leading cause of chronic kidney disease is diabetes. But when you come to Ghana, it's hypertension. What is unique about us? You go elsewhere, the global prevalence is like 10%. All the estimates in sub-Saharan Africa and Ghana is between 13 to 17%, higher than the global average. So we have a peculiar situation. So we must work at reducing the burden. And to do that, it means that we have to note as a country that our disease burden is shifting from the infectious diseases. We have a National AIDS Commission for an infectious disease. We have National Malaria Control Program for an infectious disease. We have Bruley Ulcer Control Program. All these programs were instituted at the time that our biggest disease burden were infectious diseases. Now, our disease burden is becoming non-communicable.
That's true.
So, are we going to have an authority like the AIDS Commission or something that controls non-communicable disease? That is where we should be heading to. And that authority or commission should be well financed to go into research to what is peculiar about our population that is giving us such a high burden of chronic kidney diseases. We must find answers. What is unique about us? How can we prevent it? And when we have found these answers, such a body, well-resourced, and some of the resources can come from this syntax, we can all contribute to it, because as long as we live long, we are going to encounter some of these non-communicable diseases. It's surprising to note that our current non-communicable disease policy of the Ministry of Health, chronic kidney disease is not in there as a priority. It's nowhere. Some of the conditions that lead to it, like diabetes, hypertension, are covered. But chronic kidney disease itself is not there as a priority area. And NCDs as a whole is not giving the needed prominence. It's only recently that the Ghana Health Service is trying to create a directorate for it. It was a unit. But the disease pattern has changed for the country. So we need to give it that prominence that it deserves so that we can tackle head-on prevention. I mean, I hear some of our attempt at prevention, and it's laughable. At the last thought leadership, Dr. Nsian Sari mentioned the ministry people were saying they have created wellness clinics in the hospital. And I ask myself, do well people go to the hospital?
Yeah.
If you situate a wellness clinic at the hospital, is it really meant for people who are well, or is it meant for people who are sick? Looking at the health-seeking behavior of the average Ghanaian, I see men in my hospital who accompany their wives to me, and they are proud to say that in my whole life I've never been to a hospital. They are proud about it. It's a normal thing. So if you want to catch that man, to screen him and offer him advice on wellness, should it be at the hospital? Why don't we have this wellness clinic at the sports stadium? Why not at a place at the market? Why not at a pub? Why not at a place where we can get the people? Why not at the malls? This is where wellness clinics should be. And we should incentivize people to use these services. Because we know as a nation, if we really want to solve the problem, that if we prevent them from getting sick, the burden of disease will be low and we'll spend less. And therefore, it is better to pay for them to be screened. And so when you go for a wellness check, it should be paid for. Whoever is doing that wellness check should be able to submit a bill and someone pays for it. And the NHIA or this non-communicable disease commission or authority should be interested in financing that to prevent the burden of the disease. If we did this, then the burden will come down and we can sustain whatever financing model we put in. But if we just look at the current problem, it's just 4 million debt, we can pay it. Let's do this one, let's do that, and we pay. Okay, let's instruct NHIA. We are going to go into deep, deep trouble. And I hope that we will think along these lines.
It would seem the simplest thing. Preventive healthcare. It seems the most logical thing, right? Just save money up front by not making people sick. And also cry. Kwame, solutions.
Well, thanks to if I try to propose solutions, I probably say the same thing Titus is, and I'll make a caveat here. Myself and Titus talk a lot, so our thinking sometimes is in sync. I mean, he sent me the Ghana non-communicable disease document, and I read it, and I sent him a message. I was like, Titus, are we serious at all? So a lot of the things he said, I agree with. I'm just going to add two things. The first one will be the political will. Everything Titus has said is absolutely important, but we should have the political will to fight these battles. We shouldn't be ad hoc and instructing. We should have the political will, and the political will must be bipartisan. We should have a national agenda, a national approach to managing communicable diseases, not a partisan approach. That is something we need to start thinking, and the only way to do it is to have cross-party and stakeholder conversations to try and get a framework in place that both political parties will buy. Because I don't believe that this system where, as it stands now, even in the NPP, there are people who are looking for the exit of people who are managing our health system so that they can also get into public office. And people in the NDC are sitting down waiting for hopefully 2025 for them to win the election so that everyone is pushed out so that they can come and get a job. I don't believe that is the way to manage a health system. So we need to go away from that. The second thing will be regulation. Titus has spoken copiously about prevention, and I have talked about prevention in the past. But one of the ways of preventing is to regulate the supply chain of our herbal medicinal products. I have always argued that it is bonkers that people would be very serious about what is contained in a perfume or deodorant they use and check all that, but will be able to buy at a trotro station or a bar station, any concoction that is supposed to do X, Y, Z, especially these aphrodisiacs, and drink it not knowing what it contains. I think that is crazy. But we have laws to prevent these things from happening. And those laws should be enforced as part of our preventative drive. If we continue down the lane, and that's why when people say that, our prevalence and incident rates are peculiar, I tell them because we are very strange people. We do peculiar things. So in the end, we have peculiar outcomes. And so those are the two things I'll add, apart from saying that I agree with Titus and most of the things he said.
Absolutely. I'm so glad we had the two of you this morning, because the path is clear.
Yeah.
The path is clear. We know what needs to be done, Ray. All right. I want to say a big thank you to Dr. Titus Beyuo, Senior Lecturer, University of Ghana Medical School. He also happens to be the NDC parliamentary candidate for Lambusie in the Upper West region. But he said something earlier before we came on air, actually. Or was it while we were on air? He said if we can keep our grubby hands off at least healthcare and education, our country will move a lot further. And by grubby hands, I think we mean political hands. So he says today, even though he is a parliamentary candidate, he's putting the politics aside so we can talk about actual solutions. Kwame Sarpong Asiedu is pharmacist, D&D fellow on public health, CDD Ghana. And my goodness, how long has Kwame been pointing out the glaring and obvious problem with how we are approaching dialysis treatment in this country? And it turns out that he's a prophet, right? Because exactly as he feared, it has all come to pass. As for that, the capping of the funds of NHIA for the government to spend on other things, another day we'll get into it.
I pray Dr. Beyuo gets to Parliament, and when you're discussing some of these matters in the future, you put your political cap aside, and let your professional side, which is you as a doctor with all the experience, let it show, so that we can begin really to see a lot more change in our policies.
Yeah, I was speaking to a colleague on the other side this morning, and I was telling him, I wish this kidney discussion we are having, we could have a bipartisan discussion where both NDC and NPP will say, okay, I'm bringing my medical doctors or health experts, I'm bringing my finance experts, you bring your finance expert, let's sit together and come up with a solution that we all agree to. And then something like that will get a bigger buy-in.
Right.
I think because this is non-discriminator. If you take anybody's, I keep saying, if you cut anybody's blood, you won't see NDC or MPP. And it's something we should really sometimes think out of the political lenses, and then see how we can chart a clear path for the country.
Right.
Thank you.
How anybody can prioritize politics over life beggars belief. But anyway, we see it all the time.